Okay, hi again. This is Ahmed Sayasne. I'm supposed to be as well co-chairing with this session, this very, very interesting session that I hope we will learn all from this session. I'm waiting for Professor Tombone, so hopefully he will be
Yeah,
joining.
I'm here.
Here we go. Here we go. Welcome back. So all the talk to you.
Good to see you, Ahmed.
Good to see you, Prof. Yeah. So I was just starting the session by introducing the first speaker, who's well-known figure actually in the world of ultrasound scan, Dr. Mala Sibal. She's from Bangalore, and she's worked in obs and gynae, fetal medicine. She's member of the IOTA. I know her from IOTA as well. She published many papers on different subjects of, I have to say, fetal medicine, endometrial, gynae scanning. And she's kindly as well going to talk to us about the endometrium and how to assess the endometrium in ladies with postmenopausal bleeding, which is a very interesting subject. The guidelines recently changed by the menopausal clinic, and I hope she can as well shed some light on the HRT changes. So all the platform for you, Professor Sibal.
Hello everyone, I'm Dr. Mala Sibyl and I'm going to be talking on evaluating the endometrium in women with postmenopausal bleeding and assessing them for endometrial cancer. Now, this was a very interesting article, a part of the IETA study, which showed us the various histopathologies seen in both pre- and postmenopausal women with abnormal uterine bleeding. And in postmenopausal women, a large percentage had atrophic endometrium, 21.6%. 37.6% had endometrial polyps and 14.4% had endometrial cancer, which was significantly higher than that seen in premenopausal women. Other histopathologies that were noted were endometrial hyperplasia with atypia, endometrial hyperplasia without atypia, and then you had proliferative endometrium, secretory endometrium, and so on. Ultrasound is the imaging modality of choice. When we say ultrasound, we mean transvaginal scan. But in my view, ideally in every patient, we should do both a transabdominal and a transvaginal scan because many of these patients are obese with a mid-position uterus with suboptimal views, and adding transabdominal scan routinely to transvaginal scan definitely increases diagnostic accuracy. Saline infusion sonography may be resorted to in some cases when you see the endometrium is thick, you're not seeing a pathology and she has postmenopausal bleeding, or when we see pathology but we feel our views were suboptimal and we would like to visualize it better. We look at various ultrasound features like thickness, morphology, vascularity, etc., and pathology can be suspected, and sometimes we can be pretty confident that this is the particular pathology, yet diagnosis is on histopathology. With endometrial cancer, we know ultrasound features may resemble or may be absolutely normal, or they may overlap with other pathologies like endometrial hyperplasia, benign polyps, etc. So diagnosis is on histopathology. Now, these were two interesting papers that showed us the prevalence of endometrial cancer in pre- and postmenopausal women with and without abnormal uterine bleeding, and you'll see that the prevalence was highest in postmenopausal women with abnormal uterine bleeding. So it is these women with postmenopausal bleeding that require very detailed evaluation. So how do we go about evaluating women with postmenopausal bleeding? Based on ultrasound, we triage these patients. Those where the endometrial thickness is equal to or less than 4.4 millimeters, we know they're at a low risk for endometrial cancer. So we dismiss them and we evaluate them only if they come again with bleeding. Those where we've seen a pathology or we are not seeing pathology but the endometrial thickness is equal to or more than 4.5 millimeters, we know the risk for endometrial cancer is high, and these are the patients where we require endometrial tissue for histopathology. Now, if we are seeing pathology and it's focal, we do a guided biopsy, a hysteroscopic biopsy, but if the lesion is diffuse, we can do blind sampling. Now, if the endometrial thickness is equal to or more than 4.5 millimeters, we know that the risk of endometrial cancer is high. In these patients, we need to further evaluate and look for pathology. For this, we either do a saline infusion sonography or a hysteroscopy. and we look and see if we can see any pathology. If we find a focal pathology, we do a guided biopsy. But if we are not able to find focal pathology, then we can do blind sampling. Now, here's a brief introduction to endometrial cancer before we look at the ultrasound features of endometrial cancer. Endometrial cancer is the most common malignancy of the female genital tract in high income countries, and it is the second most common in low and middle income countries. Almost 90% of these women are postmenopausal, and 90% of these patients are symptomatic with abnormal uterine bleeding. That is, the bulk of the patients are those presenting with postmenopausal bleeding. There are basically two major types. Type 1, which constitutes the majority. These are endometrioid carcinomas grade 1 and 2, which are estrogen dependent with good prognosis. And then you have type 2, which include endometrioid carcinoma grade 3 and all non-endometrioid pathologies. High risk is considered all type 2 endometrial cancers and any type 1 which is more than stage 1A. Of late, molecular subtypes of endometrial cancer have been recognized to be very important for prognostication and treatment, and these are basically of four types. You have the pole mutation, MSI, P53 wild type, and P53 abnormal type. When it comes to evaluating women with postmenopausal bleeding, it's very important that we measure the endometrium accurately. For this, we need to have a zoomed in image of the uterus, which occupies about 2/3 of the screen. We measure the endometrium where it is maximally thick in the sagittal plane, and a 2-layer thickness is provided in millimeters. If there is intracavitary fluid, then we take a single layer thickness wherever it is thickest, and we mention that it is a single layer thickness, or we can measure the anterior and the posterior where we think it is thickest and give the measurement which is in 2 layers. If you have an endometrial polyp, you include it in the measurement because after all, it is endometrial pathology. But if, for example, you have a submucous fibroid, you do not include it in the measurement of the endometrium or in the endometrial thickness because it is not endometrial pathology. If a patient has a mid-positioned uterus and it is difficult to study or even measure the endometrium, it should be reported as non-measurable and suboptimally assessed. And these women with postmenopausal bleeding and suboptimally assessed endometrium do require further evaluation with saline infusion or with hysteroscopy. So let's look at how the endometrium appears in women with endometrial cancer. As you can see in these images, the endometrium is thick, it is heterogeneous. The midline is often not seen unless the lesion is focal. If one observes carefully, you notice that the margins of the solid tissue are irregular, and this is well seen if there is some amount of intracavitary fluid, which may be because there is some amount of blood in the endometrial cavity, or there's some necrotic material or debris, or there's pus, or because we've instilled some amount of saline in the endometrial cavity. The endomyometrial junction is indistinct or irregular in patients with myometrial invasion. The vascularity of the endometrial tissue is increased and the vascular morphology is abnormal. You see randomly dispersed vessels, as you can see here. The distribution is not uniform. It looks like you've thrown in a splash of color. Not all the vessels are crossing the endomyometrial junction. In some cases, you see multiple vessels in a focal area, like in this case of a polypoidal serous carcinoma, or in this case of a focal endometrioid carcinoma, or one may see multiple multifocal vessels if the disease is more diffuse. If you look at endometrial cancer, it may involve only a part or it may involve the entire endometrial surface when the lesion is diffuse. Or less frequently, it may appear within a polyp. So you may get endometrial cancer, like in this patient, grade 2, arising in an adenomyomatous polyp. Now, to distinguish, there are basically two different types of presentations. This is a polypoidal cancer. That means there are no benign elements. It's malignant neoplastic tissue, focal protruding into the endometrial cavity. In contrast to this, these are focal areas of malignancy within a polyp that is basically a lesion that is benign, localized overgrowth of endometrial glands and stroma covered by epithelium. So the base of the polyp in these patients will be free of tumor. So it's basically benign pathology with focal endometrial cancer. Now, this study showed us that in polyps, atypical hyperplasia may be seen in 2.6% and endometrial cancer may be seen in 1.1% of cases. Now, moving on to evaluating myometrial invasion on ultrasound, this is typically seen as an irregular or an ill-defined endomyometrial junction. Now, when we want to look at the endomyometrial junction more carefully, the best thing to do is use 3D with VCI because VCI helps us delineate margins much better. Now, in this particular patient, on the right side, both on 2D and 3D, you could see that the endomyometrial junction was well seen and the overlying myometrium we've measured here was 5 millimeters. Whereas on the left side, you could see on 2D, the endomyometrial junction was indistinct, but using 3D with VCI, we could see that the endomyometrial junction was irregular. There was invasion of the myometrium with only 1.3 millimeters thickness of overlying myometrium. So we could see here on the right side, the myometrium was 5 millimeter thick. On the left side, it was only 1.3 millimeters thick, telling us that there was more than 50% myometrial invasion, which was confirmed at histopathology. Now, another way to evaluate this objectively is to use the AP by the uterine AP ratio, and the cutoff that is taken is 0.53. But here we need to be careful because if you have a polypoidal growth like this serous carcinoma, it will erroneously tell you that there is more than 50% myometrial invasion. Another thing to be careful about is not to evaluate or assess myometrial invasion in the area where you have the feeder vessels into the malignant tissue, because here the endomyometrial junction will be indistinct. Now, when it comes to evaluating the endometrium for endometrial pathology and endometrial cancer, there are two features that are very important. One is the endometrial outline, which is nothing but the endometrial surface facing the uterine cavity. If it is regular, we know it is benign. If it is polypoidal, it could be endometrial hyperplasia or just a simple secretory endometrium. And if it is irregular and cauliflower shaped, we are thinking in terms of a malignancy. Now, it's the same thing when it comes to endometrial polyps. If you have a regular outline of a polyp, you know it's very likely to be benign. If it is irregular, cauliflower shaped, could be malignant tissue like this adenosarcoma. And if it is irregular and with spiky margins, again, you know this is likely to be malignant. This was a focal endometrial cancer. The other thing that helps us is vascular morphology, which can be assessed not only on 2D, but on 3D with glass body display. You're able to see the entire vascular tree. So on 2D, here are 3 patients with thick endometrium. The first is an endometrial polyp. There's a single feeder vessel branching within the polyp. Here you have multiple single vessels crossing the endomyometrial junction and running in almost parallel course. This is normal vascular morphology and may be exaggerated or very prominent in patients with hyperplasia, but you can also see it in patients with secretory endometrium. And here is an endometrial cancer where you have randomly dispersed vessels. Not all of them are crossing the endomyometrial junction, and this is carcinoma. Now, the same thing you can see on 3D. This is the vessel entering the endometrial polyp and branching within. In hyperplasia, the pattern remains the same. You have single vessels crossing the endomyometrial junction, running a parallel course. But in endometrial cancer, you can really see the big difference on 3D. There is looping of vessels, there are multiple branches, there are microaneurysms, there are stenotic segments, there is unequal distribution, and the difference between a hyperplasia or non-malignant pathology and a malignant pathology becomes very, very obvious on 3D with glass body display. Now let's look at this patient, 59-year-old postmenopausal, who presented with second episode of postmenopausal bleeding. The endometrium was thick, it looks echogenic, there was a single prominent feeder vessel, and the first opinion or the first impression was that this could be an endometrial polyp. But when I reduced the PRF, I realized that there were multiple vessels crossing the endometrial junction and branching within, telling me it could be endometrial cancer, which it turned out to be. So when we are evaluating the endometrium with Doppler, it's very important to remember that instead of color Doppler, it's better to use HD flows or power Doppler, because these will help us pick up low velocity flow in small vessels that may be missed with color Doppler. Our Doppler gain should be maximum. We may need to lower our PRF. We can reduce our box size to include just the endometrium and the adjoining myometrium. We should avoid undue pressure with the probe. We may have to angulate or rotate our probe so that we are able to see the vessels properly. It's important to spend a few minutes observing carefully, and a transabdominal scan also very often helps. Now, here was a patient with a mixed endometrial cancer. On transvaginal scan, you see I've measured the endometrium. It's thick, but on Doppler, I could not evaluate flows at all. The views were very, very suboptimal. Now, in the same patient, you can see the endometrial thickness can also be seen on transabdominal scan, maybe slightly better than transvaginal scan, but the vascular morphology was definitely abnormal, telling us that this is likely to be endometrial cancer. Again, another patient on transvaginal scan, she had pus in the endometrial cavity, and pus is thick, hyperechoic, so you couldn't really see the outline of the solid tissue or confirm. Managed to see some flow within this tissue, but if you see the transabdominal scan, it gives you a much better evaluation. You can see the solid tissue with significantly abnormal vascularity. Endometrial cancer may spread or extend into the cervix, and here you can see there are vessels from the cervical stroma into this neoplastic tissue. It can also extend beyond the uterus into the adnexa, and this patient had bilateral tubal involvement also. So you can see here the solid neoplastic tissue in both the fallopian tubes. In this particular patient, the endometrial cancer had metastasized to the lymph nodes, to the pelvic lymph nodes. You can see the iliac lymph nodes on both sides, on the right and the left. Now, this was a 66-year-old lady with, she did not have postmenopausal bleeding, but she had pain abdomen. A CT scan had showed a mental nodule, and she was found to have a thick endometrium, and she was sent for evaluation to see. And with such a thick endometrium in a patient who already had an omental nodule, we were definitely concerned about malignancy. So the endometrium was about 19 millimeters thick. You can see the arcuate vessel calcification here. This is a short video clip. I just couldn't make out on 2D what this pathology may be. And here you can see I turned on to sepia, maybe hoping to see a little better. I thought there was some sort of an endometrial midline. There was one small cystic space. I really couldn't make out. I tried to use Doppler to see if I could see the vascular morphology, but again, it was absolutely not clear. So this is really, really challenging. And so what we did in this patient is infuse a little bit of saline into the endometrial cavity, and lo and behold, it became very obvious that this was a case of a benign endometrial polyp. The polyp had a very smooth, regular outline. And at histopathology, it did turn out to be a benign endometrial polyp. So far, what we've seen is features that suggest that this patient may have a malignancy, but there are certain features that tell us that the patient is unlikely to have an endometrial malignancy. And in this particular paper, they have shown that these particular features have a very low prevalence of endometrial malignancy or atypical hyperplasia. And these four features are a thin endometrium less than 3 millimeters, a 3-layer endometrial pattern, a linear midline, and a single vessel without branching. Now, this particular paper assessed the ultrasound features in low risk and high risk cases. And what they realized is as we moved from low risk to higher risk, the probability and intensity of endometrial pathology or features of endometrial cancer increased. So the endometrial thickness was more, heterogeneity was more, the color score was more, there were multiple multifocal vessels, irregular endomyometric junction probability increased, and so on. And so was it for the pole mutations. But what we need to be careful about is that there is a lot of overlap. So those sonographic features differ in low risk versus high risk because of so much of overlap. They cannot be used to discriminate cases on ultrasound as low risk and high risk. Here, for example, you have a patient with very high vascularity and a thick endometrium, which was just grade 1 endometrioid carcinoma with less than 50% myometrial invasion. Whereas here is a clear and a non-endometrioid pathology, which has a poorer prognosis, high grade with more than 50% myometrial invasion. But you can see here the vascularity was much lesser than what we saw over here. And therefore, just ultrasound cannot be used to differentiate between low risk and high risk cases. So to summarize, ultrasound is the primary modality of choice in women with postmenopausal bleeding. Our primary concern in women with postmenopausal bleeding is endometrial cancer, though they may have many other pathologies. Unless the endometrium is less than or equal to 4.4 millimeters, biopsy is warranted for histopathology. Ultrasound features that suggest endometrial cancer may be many, but what is very important is the outline of the solid tissue, an irregular outline and abnormal vascular morphology. Staging is possible on pelvic ultrasound, but grading or predicting whether a patient has high risk or low risk endometrial cancer is very difficult on ultrasound. Thank you very much for a patient hearing.
So while Ahmed is sorting out his muted iPhone,
sorry. Yeah, thank you. Thank you so much. I'm back. So excellent talk, Prof. Thank you so much. And there's so many aspects and so many things to learn from. Not sure. I can't see any particular triggering questions in the Q&A, but I have a question myself. I think I'm sorry if I missed the cutoffs. I know you mentioned the 4 millimeter cutoff for postmenopausal bleeding. I just wonder if there is any shed of light on HRT related cutoff. So if it is combined sequential, will that cutoff be different at all?
So when it comes to postmenopausal bleeding, the cutoff remains the same both for patients with and without HRT. So that's what the studies have shown, that once the lady has postmenopausal bleeding and her endometrium is 4.5 millimeters or more, but some studies say 5 millimeters, then that would warrant some form of endometrial tissue assessment.
Thank you so much. Great. With ladies who had previously ablation of the endometrium, what's your comment on that? You know, is ablation a factor for missing thickness on ultrasound scan, you think?
I actually have no experience with endometrial ablation, and I don't think there are many studies with it, but I know that endometrial ablation in my logic should work something like what we see in Asherman's. So I think a scarred endometrium is always a thinner endometrium, so I don't think a cutoff in my logical thinking should be the same.
Thank you so much.
Yeah, we had a look at with Olaf Istra a while ago, and we looked at endometrium and whether those endometrium. One of the questions initially with ablation was, do you have to give progestions at all, on the basis that there was no endometrium, which clearly is not correct. And we did that with Olaf, and you often get little areas of endometrium, pockets almost, with probably with the cavity stuck together in between. So I think it can be problematic, I must say, and it's a bit of a worry. Because getting in there as well, taking a biopsy is a big issue as well, of course. It's not easy.
Absolutely.
I mean, the other big question, I guess, Ahmed, and also Marla, is tamoxifen is obviously a problem. I don't know, sorry to butt in here, but Marla, do you have anything, any views on how you handle your patients who are taking tamoxifen?
Yes. So again, the cutoff for postmenopausal women on tamoxifen, once they have postmenopausal bleeding, they need to be sampled.
Yeah, I think that's it, isn't it? Really, I think in a sense, yeah, but especially because so many of them have quite thick subendometrial, that sort of cystic subendometrial changes. it's quite difficult to go on any kind of endometrial thickness anyway, I guess, and you just have to take a biopsy. Ahmed, I'll hand back to you.
Excellent. So shall I present our next speaker? Or
Well, I don't know, we'll fight over it. I'll do it.
well, but so okay. Shall I ask more questions? Because
no, I think we have to move on. I think we're going to have
okay.
to. Marla, as ever, it's a pleasure having you. Thank you so much for your great lecture, and do stay on the session if you can. And I'm sure you may be able to, you'll have something to, if you want to, contribute to the MDT. If you have any comments for any of the cases, it would be great to have you still here.
Thank you.
Thank you so much, Mala. Great speech.
So I'm going to move on to our next speech.